We know blood pressures are being done, but we need to teach people how to do it properly so that we can start doing something. Implementation comes to people who are preparing themselves. Even if as a nation we say, okay, we have enough scans in certain place, let's adopt this. But we're not going to have enough people to do intranatal Dopplers. In the same way, we may not have enough map machines. So these are some of the first steps we need to make, but there's no doubt that we need to screen for the disease. Well, the disease is causing a lot of damage that we see. And it is very painful for those women who book early, who have a scan without intranatal Doppler, only to be told that your baby is FGR at 28 weeks and the baby weighs 500 grams. It is so painful. You always think, could they have benefited from aspirin? Could we have pushed the appearance of the severity later on by administering aspirin? But all these are lost opportunities amongst our people due to a system which is not moving with the times. So we need to move with the times. I think I need to introduce the next presenter. I think he's ready. So Dr. Dwe, please stay for the questions. There is one question probably which I need to answer. I think it came late. Somebody was saying the serum markers perform better earlier on around 8, 9, or close to 11 weeks compared to the nuchal then. And isn't it better for us to do a two-stage screening process where women may come at 8 to 9 weeks to have their biochemistry done and then their nuchal done? For sure, that idea was explored a long time ago. You are right. But the reason why people came to settle at 11 to 13 weeks, the perfect time to do screening is 12 weeks. It's because the 11 to 13 week appointment is not only for aneuploidy, as you can remember. It is also to do other things, including checking for the fetal anomaly, doing fetal anomaly. You will find out that at 11 weeks, you will struggle to even see the kidneys of the baby, but you can see them better at 12 weeks. At 13 weeks, the baby is not posing nicely for the nuchal. You struggle to put the baby in a good position to do the nuchal. In most cases, it is seated. Remember, it's not both of them. They are opposite. PAPA should perform better earlier on, but beta-CG performs better later on, around 13 weeks. So a balance to be found to say what is the best time to screen these women. If a woman is to ask you, when should I go from 11 to 13 week appointment? It is 12 weeks. That's the best time in the 12 week. One, told you. And the performance of PAPA and beta-CG, they cross around 12 weeks. Like I told you that beta-CG differentiates better babies with Down syndrome around 13 weeks. At the end of the 13th week, my laptop is out. At the end of the 13-week period, while PAPA performs better earlier on around 11 weeks. So that's the reason why we talk. Problem if we put 12 weeks alone, you're going to miss a lot of women. So 11 to 13 weeks is a fair gap because it gives women, 3 weeks to come for screening. Right, so the next speaker is Mr. Chigayo. Mr. Chigayo is a radiographer who is almost a sonographer now. He is passion for fetal medicine, and Mr. Chigayo, besides the medicine unit, I've also worked with him. So he has developed a strong interest in the fetal defects. I think even his diagnosis of fetal conditions is becoming more and more accurate. I even see some of the patients that you have scanned outside. I no longer doubt his diagnosis now because in most cases it's spot on. So he is a budding specialist in fetal defect diagnosis. So this is Mr. Chigayo, who is going to present to us on fetal anomaly scan excluding the heart. Please go ahead, Mr. Chigayo.
Okay, thank you, Dr. Verenga. Good afternoon to everyone. Okay, so today I'll be presenting on fetal anatomy scan excluding the heart. So basically, the anatomy scan or anomaly scan is done to check for structural fetal abnormalities or fetal survey. It is also done to check for markers for chromosomal abnormalities. It is also done for dating if the patient doesn't have any dates, or it is done for growth assessment if they have prior dating scan or they know their last normal menstrual periods. It is also done for screening for preterm, as previously mentioned, and it is also done for screening for risk for preeclampsia. Then from the on the next slide, worldwide congenital anomalies constitute around 270,000 of all congenital anomalies according to statistics, which is almost 10%. So congenital abnormalities constitute quite a large number of fetal deaths. Then locally, the prevalence of these defects based on cohorts done at Harare Hospital, looking specifically on the central nervous system, ventricular megalith tends to be with the highest prevalence, then anencephaly, and then we also have anode chiari, and then meningocele, and then we also have sacrococcygeal teratomas. So we are going to discuss some of the pathologies that are on this cohort, especially the ones with the highest prevalence, like ventricular megalith, anencephaly, and holoprosencephaly. Then we move on to the GIT and the abdomen. So according to the cohort done at Harare Hospital, fetal ascites is the highest prevalence. There's also gastroschisis, exomphalos, and then there's jejunal atresia, amniotic band syndrome. So all these pathologies are very common, as you can see from the frequencies that they are picked from the cohorts done at Harare Hospital. Then from the renal defects, hydronephrosis, echogenic bowel, and then multicystic kidney. These are the common pathologies that they anomaly picked during the anomaly scans. So the effects of undiagnosed abnormalities. Undiagnosed abnormalities significantly increases the perinatal mortality and morbidity and maternal morbidity. So the undiagnosed abnormalities affect both the mother and the child. Undiagnosed abnormalities impact upon clinical outcomes, sometimes with devastating consequences. So specifically looking at the child, when the defects are not diagnosed, the child has a missed opportunity for in utero fetal therapy. So for some conditions, when we diagnose, there is an intrauterine procedure that can be done to relieve this from to relieve the child from the effects of congenital diaphragmatic hernia. Then also lower urinary tract obstruction in these cases, relieving the child from this obstruction before birth can protect the fetal kidneys. Then we have also another effect, which is missed opportunity for fetal surveillance and assisted delivery. So when we do not pick the abnormalities, sometimes the child misses the opportunity for fetal surveillance, as we know that surveillance might be introduced in fetuses that have abnormalities. So when we don't pick the abnormalities, then the mother is not going to be followed up, and eventually this might also lead to devastating outcomes like fetal death. And then the other thing is that there is inadequate preparation. As we know that for some pathologies, we have to prepare for the child, especially during delivery and soon after delivery, so that the prognosis of that pathology is greatly improved. In cases where there is, for example, or exomphalos, the survival rate is 90%. But if the child is delivered at the wrong place, where there is no when there's no at a non-surgical center, then the prognosis decreases to 20%. Similarly to duodenal atresia and gastroschisis. So if we do not diagnose these pathology, these defects, then this child will miss or will be delivered at the wrong place, and the survival chances will then be lowered. We move on to the effects on the mother. When we do not diagnose these congenital abnormalities, this will lead to unnecessary cesarean sections being done to the mother. Why? Because most probably the defects, because of the defects, the fetus might not be able to undergo the process of normal delivery. Hence, the mother will then have to, a cesarean section will have then to be done to deliver the baby. And then interventions for fetuses who cannot survive. So after noticing later on that there's a defect of which the child cannot undergo the normal spontaneous delivery, then the mother is forced to have a C-section for a child, most probably that will not survive if the pathology is lethal. Then the mother is also deprived of perinatal palliative care to enable them to prepare for their baby's death. That is in cases where the condition is lethal. Then there's also another effect on the obstetricians, which will continue to deal with unexpected birth outcomes and sometimes extremely complicated deliveries because of the abnormalities on the baby. Right. So the anomaly scan is usually performed between 18 and 22 weeks of pregnancy. All pregnant women should be offered this scan. The anatomy of the fetus is checked systematically from the head to the toes. Each practice should develop a protocol so that we do not miss these abnormalities. So, for example, when we are doing the 18 to 22 week scan, that is the anomaly scan, we should then be able to fill in these all this information to say whether the head is normal or is abnormal, or whether you might not have been able to examine that particular part of the head, the face, the thorax, and the rest of the body. So after doing the anomaly scan, we should be able to completely fill in this table for us to say we have completely done the anomaly scan, and for us to be able to identify all abnormalities that will be present. So how then can we do the anomaly scan? We now move on to how we assess the fetus to rule out abnormalities during the 18 to 22 week scan. So we first of all assess the head. When we are doing the scan to assess the head, we should assess the head at the level of the transventricular plane. At this level, we should be able to see the anterior horns of the lateral ventricles. We should also be able to see the cavum septum pellucidum, which appears as a triangular box in the anterior compartment. Then we should be able to see the midline, the flux, and we should also be able to see the thalamus on both sides. And then we should also be able to see the posterior ventricles on both sides. And unfortunately, in this case, there's some shadowing, maybe probably because of the skull. So at this level of the ventricles, that's where we diagnose ventricular megaly when the ventricles are dilated above 10 millimeters. We also want to check the shape of the head, as it should be ovoid, and it should not be lemon-shaped, that is scalloping, and it shouldn't be strawberry-shaped or clover-leaf shaped. Then after doing after assessing the head circumference, we move on from the transventricular plane. We move on to the transcerebellar plane, where we want to assess the cerebellum and the cisterna magna in the nasal fold. In this plane, we are expected to see the cavum septum. We also expect to see the cerebellum, the vermis of the cerebellum, and then the cisterna magna, which is a fluid filled space behind this cerebellum. At this plane, we should also see the vermis, but it is better appreciated in the coronal plane. So there shouldn't be any communication between the fourth ventricle, which usually lies just in front of the vermis, and the cisterna magna. We shouldn't, the cisterna magna should be assessed also to rule out mega cisterna when the AP diameter is more than 10 millimeters. The cerebellar vermis agenesis should also be ruled out to exclude conditions like Dandy Walker malformation and mega cisterna magna and the black pouch cyst. After doing these planes, the transventricular and the transcerebellar plane, we move on to check the face of the fetus. When we are assessing the face of the fetus, first of all, we should assess the profile where we are supposed to see the nasal bone, the maxilla, and the mandible. We should be able to see these three structures for us to say we are in the correct mid-sagittal plane. We are also supposed to assess the orbits, and we should be able to see the length of the orbits. We should be able to assess the distance between the orbits. There should be the distance between the orbits for us to exclude conditions like hypothyroidism. There should be enough space to fit at least one orbit in between the two orbits. If there is more space between the orbits, then which fits more than one orbit, then there is most probably hypertelorism. Then we should also assess the palate to see whether there are any defects to rule out cleft palate. We should also assess the nose, in the upper lips and the lower lips to rule out a cleft lip. Then if possible, we can also do the 3D image. From the head, we have to move on to the abdomen. At the level of the abdomen, we have to assess, first of all, we have to assess where we check the abdominal circumference, where we are supposed to see the stomach bubble. We are supposed to see one complete rib to make sure that we are not oblique. And then we are supposed to see the adrenal gland. And we are also supposed to see the umbilical vein as it enters the portal sinus. We are also supposed to see the liver, and we are supposed to see the aorta more to the left side, and the IVC, which is not very clear, on the right side. So we should make sure that every time we do this assessment, we should be able to see the stomach bubble, as absence of the stomach bubble with associated polyhydramnios might be a diagnosis for esophageal atresia. We then, still on the abdomen, we are supposed to see, assess the condensation into the fetal abdomen when we want to rule out conditions like gastroschisis and exophalos. We are also supposed to assess the umbilical condensation at the placenta. Then we should also assess the kidneys, both in transverse plane and in coronal plane, where we apply color Doppler to see flow the renal kidneys into the kidney. We see flow into the kidneys. Absence of renal flow might be indicative of renal agenesis. We are also supposed to see the umbilical arteries surrounding the fetal urinary bladder. We are also supposed to check the kidneys on both sides and measure the renal pelvis to exclude conditions like polyhydramnios. In this case, they were not measured. Okay, then we move on to the spine. When we are assessing the fetal spine, we are supposed to assess the fetal spine in both longitudinal, in longitudinal, axial, and coronal plane. We are supposed to see all the vertebra up to the sacrum. And we are also supposed to see the most distal part to exclude some meningocele that occur distally. And then when we are also assessing the spine, we are also supposed to see the cisterna magna, so that the fluid behind the neck, this fluid that is indicated over there, which is the cisterna magna, so that we exclude pathologies like meningocele. Then from the spine, we move on to the anatomy of the extremities. We are supposed to assess both the lower and the upper limbs, from in this case, from the femur, the tib, fib, and the foot. There's another image that we are supposed to include, where we assess the angle of the foot from the tib, fib. So we have to take our measurements on the diaphysis and exclude the epiphysis. And then on the upper extremity, we are also supposed to assess the humerus, the radius and ulna, and all the digits. After having done all that, then we can then be able to fill in this table and completely, and in that case, we know that we have completely done the anomaly scan. So it is very important for us to make sure that we develop a protocol that we use when we are doing the 18 to 22-week scan, so that we make sure that we do not miss anything. So from the anatomy survey, we are now going on to the abnormalities. So we are going to begin with ventricular megalith, which is one of the most common pathologies that is seen. So as we previously mentioned, when we are assessing ventricular megalith, we should assess it at the level of the atrium of the posterior lateral ventricles. So these are some of the key features that we expect when we say we've thoroughly assessed the fetus to rule out ventricular megalith. So first of all, we should measure the ventricles at the transventricular plane, where we see these posterior and the anterior ventricles. It is this superior plane that we are talking about. So the cerebral hemispheres on both sides should be symmetrical, meaning that the distance from the midline to the outer margin on top and below should be the same, which means that the cerebral hemispheres are symmetrical. The glomus of the choroid plexus should be in view. The glomus of the choroid plexus is this echogenic structure. Then at the level of the parieto-occipital fissure, so this measurement should be done at the level of the parieto-occipital fissure, which is at this point. Then the calipers should be placed at the inner margins of the ventricles, meaning to say they should be placed in the inner, not the outer margins. Then the measurements is made in should be measured. The ventricles should be measured perpendicular to the long axis of the lateral ventricle. So the measurement should be made at a perpendicular angle. Then if the measurement of the atrium is more than 10 millimeters, then there is ventricular megalith. So we are going to define it in the next slide. Then the reason why we use this specific position to measure the ventricles is because first, this is the first area to dilate in the fetal ventricular megalith. So this posterior portion at the level of the atrium, it is usually the first area to dilate when the ventricles are affected. Then it dilates to a greater extent than any other region of the lateral ventricles. There's also lack of constriction from the striatum in comparison to the anterior portions of the lateral ventricles. So the axial diameter also remains constant between 20 and 40 weeks of gestation. So any measurement that is above 10 millimeters is considered as abnormal. So long we are above 20 weeks to 40 weeks, the measurement, the axial diameter remains constant. So any measurement above 10 is considered to be abnormal. It was perpendicular to the ultrasound beam in the transventricular plane. That's the other reason. And measurement has a low intra and inter-observer variability. So meaning to say that even wherever the measurement is done, if it is done in another place, the outcomes usually are the same. Then
Simba, we've lost your slides. Maybe you might want to bring them back.
Okay.
Mm-hmm. Right. So those who have questions, while Mr. Chigayo is going through the presentation, please pose your questions in the chat box, including all the previous presenters, starting with Dr. Dwe's presentation. You are more than welcome to pose questions. Please proceed, Mr. Chigayo.
Okay, just a minute. Okay, so we were discussing ventricular megalith. So we were saying the last point was that there is a low false positive. There's a low false positive when we measure the antral when the antral diameter is greater than 10 millimeters. So basically, the definition for ventriculomegaly is an antral. So the definition is an antral diameter greater than 10 millimeters. So it can be divided into severe and mild. So mild ventriculomegaly is antral diameter, which lies between 10 and 15, and severe ventriculomegaly is antral diameter greater than 15 millimeters. It can also be classified as isolated ventriculomegaly, or it can be isolated ventriculomegaly when there are no other abnormalities, and then symmetric ventriculomegaly when the difference in antral diameter, the right and the left is less than 2 millimeters. Then asymmetrical ventriculomegaly when either unilateral ventriculomegaly or a difference of greater than 2 millimeters in the antral diameter is observed. Then we move on to the etiology. So it can be as a result of obstruction or as a result of a non-obstructive cause. So some of the obstructive causes include aqueductal stenosis, intraventricular hemorrhage, intracranial tumor, Chiari 2 malformations, maybe Dandy Walker malformation, and the non-obstructive causes of ventriculomegaly might include Down syndrome or some infections. And then, so for us to be able to diagnose the actual cause for the ventriculomegaly, it is very important for us to take thorough history, which includes family history, a previous pregnancy or child with a malformation, previous fetal or neonatal intraventricular hemorrhage, maternal medical disorders, or a history of fevers or exposure, or pets at home, history of traveling to endemic areas. We also have to do an extended neurosonograph. And then we also have to carry out some tests. And then, if possible, we can also do an MRI. So the prognosis of ventriculomegaly varies depending on the etiology and associated lesions or syndromes. Then from still on ventriculomegaly, there's also hydrocephalus. So when the cause is obstructive, then it is now a case of hydrocephalus rather than ventriculomegaly. Then we move on to holoprosencephaly. So holoprosencephaly is a lethal condition. Diagnosis on ultrasound begins from 11 weeks, which means that this pathology should be diagnosed during the 11 to 13 week 6-day scan. It is when there is total or partial failure of separation of the proencephalon into two separate hemispheres. So depending on the level of separation that is happening on the hemispheres, there are 4 variants of holoprosencephaly that can be derived. So there is the lobar type and the semi-lobar type, of which these two are the most lethal conditions. So the lobar and the middle variant have a better prognosis, but a lobar and semi-lobar are the most severe forms of holoprosencephaly that should always be diagnosed. So the prevalence is, these statistics from data collected from the UK, is 1 in 1,000 births. Etiology, a lobar and semi-lobar, they are associated with chromosomal abnormalities, which include trisomy 13 in 47% of the cases. The diagnosis for holoprosencephaly is done by ultrasound, and there are some associated features for holoprosencephaly, which include hypotaylorism. Hypotaylorism, as we mentioned earlier on, that there is the distance between the two orbits is reduced, that we cannot fit another orbit in between. Then there is cyclopia, when there is just a single eye, and then there is also facial cleft when there is a defect on the lips, and then there is nasal hypoplasia or proboscis, which proboscis is a structure that forms on the forehead of the child. So management, there are some there's fetal karyotype, and then when there is a lobar or a semi-lobar holoprosencephaly, in most cases the mother is offered a chance to terminate, as the prognosis is very poor. So the lobar holoprosencephaly on ultrasound, there is this is the most lethal condition and is the most severe form. There's a single monoventricle and fused thalamus. Like, so from this image, we can see that there's a single monoventricle and the thalamus is fused. So we have also some associated features like hypotaylorism, like in this case where we cannot fit another eye in between. Then there might also be a cleft lip and palate, and also other abnormalities in the extremities and within the abdomen. So in semi-lobar now, there is the posterior part of the fetal head is partially separated, but still there is a single monoventricle, and part of the thalamus is fused. Then in the lobar and middle variant, usually the anterior lateral ventricles communicate, and there's also absence of the cavum septum pellucidum. So the lobar and middle variant are a bit more severe than the lobar and semi-lobar, which are lethal conditions. Then from holoprosencephaly, we move on to Jandy-Walker malformation. So in Jandy-Walker malformation, we diagnosed Jandy-Walker malformation at the transcerebellar plane. So from those planes that we initially mentioned previously, the transventricular and the transcerebellar, it is at this plane where we diagnose the abnormalities of the posterior fossa. So in Jandy-Walker malformation, there is communication between the fourth ventricle and the cisterna magna. There is agenesis of the vermis, which is the structure in between the two hemispheres of the cerebellum. So agenesis of these vermis will result in the posterior fossa abnormalities, which also include Dandy Walker malformation. Okay, so there are certain pathologies which may appear similar to Dandy Walker malformation on ultrasound, like megacysteina magna, the black pouch cyst, and the vermin hypoplasia. So the coronal plane now, in this case, it's not very clear, but the coronal plane now is the one that becomes very important to distinguish.
We have lost you, but we've lost your slide.
Okay,
And,
let me try to connect again.
But are you winning? If you are not too, are you winning?
I'm trying to connect again. Just a moment.
All right. To our guests, please bear with us. Our presenter will reconnect with us shortly, then we can proceed. Simba, do you...
Just a minute.
What has happened to your device? Have you disconnected? We wanted to...
Just a minute, I'm almost done. Okay, sorry for the inconvenience. So we were discussing Dandy Walker malformation. Then we moving on to acrania. So acrania, is also a lethal condition that should be diagnosed during the early obstetric scan. So in our cranium, this is a neural tube defect. So the structure that forms the neural tube during the 4th or the 5th week of embryology is supposed to fold and close to form the neural tube. When this folding doesn't happen properly cranially, then we are going to have abnormalities like acrania. And then when it doesn't fold properly along its length, then we are going to have abnormalities like open spinal bifida, which we are going to discuss later. So acrania should be diagnosed during the early 11 to 14 week scan. The definition is absence of a cranial vault with visible cerebral hemispheres. Then as the pregnancy progresses in the herniation of the brain structures, then we have anencephaly. So this is a lethal condition, and on ultrasound, despite failing to see the brain structures, we also see the frog's eye appearance. Then the prognosis is poor, as we mentioned, it is incompatible with life. Then we move on to open spinal bifida. So open spinal bifida is another neural tube defect. There is on ultrasound, there are indirect and there are also direct signs. So the direct signs are a C or a U shape on the vertebra when we are scanning in transverse, instead of the vertebra converging along the center, there is a C or a U shape in the appearance. Then the indirect signs include a scalloping of the fetal head, which is anterior curvature. There's also anterior curvature of the cerebellum to form the banana sign, and there's also obliteration of the cisterna magna. So it is associated with Talip's bladder distension, hydronephrosis. Chromosomal abnormalities are okay in 8 to 16%. Then karyotyping is done, especially if not there's no other association. Then fetal therapy is still experimental. Then when we move on to the abdomen, when we do the scan for the abdomen, as we mentioned earlier, that we should always see the cord insertion. In exomphalos, there is herniation of the liver and some of the abdominal contents within a sac at this position. So the umbilical cord then attaches to the sac. The attaches on the apex of the sac containing the abdominal contents. So when you are trying to take this image, eventually you see a mass which is the membrane containing the abdominal contents. Then for gastroschisis, there's herniation of abdominal bowel. So gastroschisis, there's no membrane, and then the contents are usually on the right side of the cord insertion. So when we are doing this assessment at this level, that's where we diagnose exomphalos and gastroschisis. Then we move on to duodenal atresia, where there is a double bubble sign that we see on ultrasound, and as a result of an enlarged stomach and the duodenal cap. So atresia, so this is the sign that we see for duodenal atresia. And for esophageal atresia, initially we mentioned that when we want to do the abdominal circumference, we don't see the stomach bubble, and then we can also diagnose We can also diagnose ileoduodenal atresia, where there is dilated small bowels greater than 15 millimeters. So duodenal atresia is also associated with polyhydramnios, and then trisomy 21 are found in 30% of cases. Delivery is done at 38 weeks. The survival rate is usually greater than 95% if delivery is done at the proper place. Then this is an image of gastroschisis where there is no membrane, and it usually happens besides the insertion of the umbilical cord, usually on the right side. Then a delivery is done in 38 weeks. So this one, trisomy is not increased, which means that this one has got a better prognosis when compared to exomphalos. Then we move on to urinary tract abnormalities, which include hydronephrosis, which has got the highest prevalence from the cohort that we initially presented. So dilatation of the renal pelvis greater than 10 millimeters is considered as mild hydronephrosis. So when we diagnose hydronephrosis, we should go on and check the urethra if possible to see where the obstruction is happening. If we don't see any obstruction, sometimes when it is isolated, then it might be as a result of a marker of chromosomal abnormalities. Then we also diagnose posterior urethral valves, which will appear on ultrasound as a distended bladder with thickened walls and a keyhole sign. I think that's all. Thank you.
Thank you very much, Mr. Chigayo. There are some questions in the chat box. Probably you can start tackling them now. Then as soon as the next two presenters are done, we'll open the floor for questions. To our guests, we just have two presentations for the day. Then we can call it a day. Then we can pose all the questions you want at the end. The next presentation, Mr. Chigayo, you may stop the screen sharing for now.
Okay.
Then so that I could share my screen. So the next presentation really is to try and address a gap which is there in our practice